Welcome everyone to Braintree this afternoon on this beautiful Canterbury day. It's nice and still out there and not windy, which is very nice. I would also like to welcome our viewers that are joining us live in Ashburton and Wigram, Somerset Village today, which is a first for us. My name is Kirsten Cairns and I'm one of the Health and Wellbeing Advisors here at Multiple Sclerosis and Parkinson's Canterbury. Before we proceed with this afternoon's procedures, in the unlikely case of an emergency, just a few housekeeping things, there is an emergency exit just over there, you'll see, and then also we can also disperse out the back of the building and out the front of the building. We have our bathrooms. Most of you will be familiar. We have our bathrooms at Braintree. They're just across the hallway here, or if you need a slightly more accessible bathroom, there is just one opposite the gym. A gentle reminder, please, to have your phones on silent. That would be much appreciated. This afternoon, we have an informal educational session planned for you called Ask Me. This is loosely based around the questions many of you have submitted. This is a great opportunity to gather together and learn, but also to support each other, knowing that many of you have similar concerns and queries around living well with Parkinson's disease. And to answer your questions, we're very grateful to have Professor Tim Anderson join us this afternoon. Many of you know Tim, but I will introduce him formally. Professor Tim Anderson is widely regarded as one of New Zealand's leading experts on Parkinson's disease and movement disorders. He serves as Clinical Director at the New Zealand Brain Research Institute and holds the Cass van der Veer Chair in Parkinson's and Movement Disorders at the University of Otago, Christchurch. He also co-directs the Christchurch Dementia Prevention Research Clinic, leading efforts to identify early indicators of dementia and Parkinson's progression. Tim's work has helped shape how we understand Parkinson's, not just the physical symptoms, but the cognitive changes and early markers that can guide better care. He's deeply involved in research and clinical trials, always looking for ways to improve life for people living with Parkinson's. Tim's contributions extend internationally through collaborations and clinical trials, giving patients access to innovative therapies and shaping global research standards. His dedication reflects not only scientific rigour, but a deep commitment to improving lives. Please join me in welcoming Professor Tim Anderson.
Thank you for bearing with us while we work out the technology.
1, 2, 3. Can you hear me okay? Try that, but that's not too loud. Not too loud, can you hear me?
Good for everybody?
Okay, great, thanks. Thanks, Kirsten. Thanks for that. I'm sort of blushing for that introduction. Very nice, thanks. No, it's great to be here. I've done one of these, I think, either early this year or maybe last year. The time was taken up with questions, which is great. Just not trying to refer us. I'm not going to present anything formal. It's not going to be a PowerPoint. I'm really just going to, after maybe a brief introduction, just answer the questions that have been delivered before, but also taking questions from the floor. And in fact, as I'm going along, I'm happy for you just to interrupt us rather than trying to remember what you want to say, half an hour later, which is not that easy for all of us as we get old.
I think maybe because we're ad-libbing now just on one microphone, I think, Tim, if you're happy just to do the questions yourself.
Yeah, sure, absolutely.
I think that would be the easiest way.
Yeah, no, that's fine.
Thanks,
great. So before I get to those questions, I thought I'd just do a brief introduction about what we think we know about the cause of Parkinson's, how it comes on, how it spreads in the brain, just as a general introduction, and then we'll just move on to more specifics that you may want to know. So the current thinking about the cause of Parkinson's is that there's a combination between genetic susceptibility, so this is for the majority of people with Parkinson's, there's a combination of genetic susceptibility and environmental factors, as in actually many things in medicine. When you think about it, cancer is a very source. So by genetic susceptibility, I mean it's something different for different people. Very rarely, there are genes that cause Parkinson's, and if you have that gene, you will get Parkinson's in your lifetime. If it's an autosomal recessive gene, you may get it early, or even if it's autosomal dominant. But if you have that gene, you'll get Parkinson's sometime in your lifetime. They are rare. Some of them are autosomal dominant. By that I mean, like Huntington's, you inherit that gene from one of your parents. And in those situations, if the parent has that particular gene, and for example the SNCA gene, then each child of that parent will have a 50% chance of inheriting the gene, 50% chance that they don't. But those are rare. And then at the other end of the scale, and this is true for most people with Parkinson's, what we call sporadic Parkinson's, there are susceptibility genes, at least 90 susceptibility genes, where if you inherit one or a bunch of those genes, your susceptibility to getting Parkinson's, sometime during your life, usually later, is a little bit increased compared to your neighbour who may not have inherited those genes. So we know that these susceptibility genes confer you just a little bit of an extra chance of getting Parkinson's than what you might have if you didn't have those genes. And so we know that about 90 of those so far, and there's probably going to be more identified. That if you have one or more of those susceptibility genes, that doesn't mean you'll get Parkinson's. It just means you're a bit more liable to get Parkinson's. Something else has to trigger it off. And that has to be things in the environment, one way or the other. So exposures that you will have had sometime during your lifetime, probably or if you're older onset Parkinson's, maybe 8 different exposures. You could call them hits if you like. We don't really know what those are. We know that if you give industrial doses of some pesticide, for example, in rats, you can cause Parkinson's in those animals. And so if you give industrial doses of toxins to maybe a person with susceptibility from their genetic makeup, that person might get Parkinson's. But for an individual person, you cannot prove that, oh, I did all that weed spraying when I was 20 and that's why I got my Parkinson's. You cannot identify in an individual that was the cause of their Parkinson's from some environmental exposure. You can say, well, that would be maybe a contribution, but you can't say that was the cause. So it's not easy. We still don't know. We don't know what pollution might have. The incidence and the prevalence of Parkinson's is increasing. I'm sure you're aware of that. It's the fastest growing neurological disorder beyond anything, beyond Alzheimer's, beyond migraine, beyond any other neurological disorder. So there has to be a suspicion that not only is it age due to people living longer, so the longer you live, the more chance we will have of getting Parkinson's. And we've done a New Zealand prevalence study, which we did a few years ago, and we're repeating it as we speak. The peak age or peak incidence of Parkinson's developing is 80. So, and when I first started training, it was 60. So we know it's been a shift in terms of age of onset of Parkinson's because people are living longer. Sorry, there's a question.
Is there a relationship between head injuries, say in sports, and the onset of Parkinson's?
Right, a good question. So the question is there a relationship between head injuries, in particular sports, but really what you're meaning is head injuries, and Parkinson's? The answer is yes. There is a relationship, but it's not necessarily a direct cause. See what I mean? It's one of these environmental exposures that we know is related to the incidence of Parkinson's. So people, especially with multiple injury, head injuries, are at a little bit more risk of getting Parkinson's than the person who doesn't. But it's not you can't prove that's the cause. It's not a direct cause. It's not true of Alzheimer's actually. There's no such information on, or no causation or association with Alzheimer's disease, but there is for Parkinson's. That's correct. But there are a lot of other potential associations, like living in a rural community, being a health worker, being a teacher. There's quite a few associations, but they're not really strong associations. Even head injury is not a really strong one. But it's one of those environmental aspects that in the mix. What we don't know is if if you have a specific genetic makeup, does that make you more liable to get Parkinson's from your genetic makeup? The answer is possibly true, but we still don't know enough about all that. I mean, Parkinson's, we call it Parkinson's as if it's one disorder, but actually we think it's many, many different disorders, if you like, all culminating in a common bunch of symptoms. And as you may know, for me to make a diagnosis of Parkinson's, I have to see 2 out of 3 cardinal features, main features. One of those has to be bradykinesia, slowness of movement. And so I have to see slowness of movement to make a diagnosis of Parkinson's, plus one of the other 2 major cardinal features, which are rest tremor and rigidity, which is stiffness. But some people with Parkinson's, ordinary Parkinson's, which is what most people have, will never have tremor in their whole career with their Parkinson's. So you don't have to have tremor, for example, to make that diagnosis. Anyway, I've diverged a little bit from the genetic makeup. Yes, some genes cause Parkinson's, very rare. Majority of people with Parkinson's, especially later onset, and as I mentioned, the peak incidence and prevalence at the age of 80. Actually, if you survive to beyond 90, then the incidence of Parkinson's goes down. So you're less likely once you get 90 to get Parkinson's. If that's any comfort to anyone who hasn't got it so far, plans on living to a ripe old age. If you get past 90, you can think, oh, that's pretty good, pretty okay. So, in reality, we don't know the cause of people's Parkinson's. As I mentioned, it's probably a bunch of different disorders. So, if you have a whole genetic susceptibility with a few genes, and you have a certain environmental exposure, your type of Parkinson's may be different from the next person's. And you'll be aware, I'm certainly aware, because I see a lot of people with Parkinson's, that some people's Parkinson's is just very, very slowly progressive, doesn't move much year by year, and the response to treatment is different in different people with Parkinson's. So, and the variety of different symptoms that people with Parkinson's develop can be different than other individuals, different individuals. So, it seems on the face of it, from when we see people with Parkinson's, and you'll be aware of this yourselves if you have Parkinson's and you can mix with the field of Parkinson's, everyone's different. And that probably relates to your different genetic susceptibility, exposures over your lifetime, and other factors we don't know. So that's why we think you could argue that Parkinson's is a bunch of different Parkinson's, all making up this a fairly common complex. Or we could say these are the lumpers and the splitters. If you're a lumper, you say this is Parkinson's, it's got these 3 cardinal features, and it's all the same condition, just minor variations of the theme. Or you can say, well, every person with Parkinson's is different, they've got different genetic makeup, response to treatment's different, progression's different, therefore they've got those individuals with Parkinson's have got a different form of Parkinson's. So it's a bit academic, but ultimately it'll be really important to be able to tease out the different presentations of Parkinson's, and are they due to different genetic susceptibilities and environmental exposures, and therefore do those folks with this particular genetic susceptibility and this particular exposure, would that person respond better or differently to a disease-modifying drug, a preventive drug, than person B who's got a different makeup? That's all for the future. At the moment we can't do that. There's individualised medicine not available yet. So that's the sort of background of what we think might be the cause of Parkinson's. And for example, while we're dealing with genetics, and there was a question about genetics, for most people who have Parkinson's, most people in this room have Parkinson's, you will not pass on your Parkinson's to your family. You might pass on a bit more of an increased susceptibility to your family. A person's lifetime risk of Parkinson's is 1 in 40. So if you pass on a bit more susceptibility to your children, they may have a slightly higher risk than the rest of the population, but not an awful lot. So you don't actually pass on Parkinson's in the family unless you've got one of those rare genes that I mentioned. That if you pass that on, that your child who's got that gene will get Parkinson's. In between, there are 2 main genes that increase the susceptibility to getting Parkinson's by more than what I've just mentioned about these 90 susceptibility genes. One of those genes is called the glucocerebrosidase gene, GBA1, if you read it. That will increase people, and there's about 100 different variations of that gene, mutations that is. If you have a mutation of the GBA gene, GBA1 mutation, depending on the type of mutation, will give you an increased susceptibility, beyond what I mentioned for the 90 different susceptibility genes. It will make you more likely to get Parkinson's than those folks with those susceptibility genes, the 90 variants. And some are more pathogenic of these GBA mutations than others. We looked at our Canterbury cohort at the NZBRI, many of you will be participating in that, thank you. And about 8 to 10% of people with ordinary Parkinson's will have the GBA gene mutation. Now, if you have that mutation, there are many mutations. One might be a bit more likely to cause the Parkinson's in that person than another form of mutation, which may be less likely. So there's variations within that GBA. But essentially 8 to 10% of people will have that, do have that GBA mutation, and that will increase susceptibility to getting Parkinson's more than the ones I just talked about, the 90 different genes, right? And that can be passed on to the next generation, which will increase their susceptibility, in children, but more than if you had ordinary Parkinson's from the genetic susceptibility of the 90 genes I'm talking about. I may have confused you. So, on one end is you will get Parkinson's if you get that gene, very rare. You may get Parkinson's if you've got one of these or several of these variants, of the 90 variants, plus the environmental exposures. And then if you're one of the 10% or a bit less of the people with the GBA gene mutation, then you're a bit more likely to get Parkinson's, but there has to be other things as well, including environmental exposures of the sort we just already mentioned that we don't know enough about. So there was a question about, you know, if I have Parkinson's, will it be passed on? I've answered that hopefully in a sort of a slightly confused way, but I think you might have got one draft. Yep. Are there any questions related to that? It's a concept that's sometimes difficult to grasp. And, you know, I wasn't brought up with genetics, so I have to sort of try and keep up with the field. It's a very evolving field. Question?
No, I was just wondering, do you do any blood testing to look at people's genes?
Yes. So the question was, do we do blood testing to look at people's genes? The answer is we do not do it clinically. So if someone comes along with a new diagnosis of Parkinson's to my clinic, I don't say, oh, right, I'm going to test as many genes as possible to see if that might be one of whether you may have a bit of susceptibility, because it will not alter what I do in terms of treatment, and it doesn't have much in the way of implications for the family. Unless it's one of those genes that I know causes Parkinson's, and we have had a family here in Christchurch who had one of those genes where it was passed on in the family. And in that case, you would definitely do the gene test. If the person is very young onset, maybe 20s or 30s, of their Parkinson's, then I might do a genetic test then. But usually that's also recessive, so it's not likely to be passed on to the family, but it's quite good to know. But for the most people who come along with Parkinson's at a later age and without a prominent family history, most people will have someone in their family with Parkinson's just by the raw probabilities, you know, an aunt or one grandparent. But unless there's a strong family history, I tend not to do the gene testing. For research, it's a different matter. So some of you will be participating in the research that we do at the NZBRI, and some of you may have participated in the New Zealand-wide research called the PET study, which Tony Pitcher and Daniel Mile from our institute have been sort of the PIs of, principal investigators of. That particular study is asking 500 people with Parkinson's around the country, not just Canterbury, and 500 people from the electoral roll who don't have Parkinson's to participate in the study, and there's a survey that gets sent out, which takes about 2 hours for people to fill in on the internet. Some of you might have had to struggle with that. So that is collecting tons of information. It's called PEGS. It's about Parkinson's environmental and gene study. So in New Zealand, we're trying to find out in New Zealand what are the particular environmental influences that may, maybe these, the influences in New Zealand, peculiar to New Zealand, separate from other countries. And what are the genes, what's the mix of genes that we might have here in New Zealand that might add to someone getting Parkinson's. And those, for people participating in that study, and you're welcome to join it if you wish, those people are contributing saliva samples, and they get sent off to the States to the Michael J. Fox Foundation derivative called GP2, which stands for Genetic Program of Parkinson's and GP2. Yeah, I've forgotten what it stands for exactly, but it's basically looking for genetics in Parkinson's. And they do a whole huge analysis of all the possible genes that may possibly contribute to people getting Parkinson's. We are getting those results back, but we haven't fully analysed them yet. And if there's any important genes that for example, you might find that someone's got a cancer-causing gene, then we would tell people. So important genes, or if it was a gene that was definitely caused with Parkinson's, we would tell people. But if it's just one of the susceptibility genes, then we don't, because part of research really, telling people doesn't necessarily help. So routinely in the clinic, no, unless there's a real reason, important for the patient and the family. But for the standard person, I call it standard, coming along with Parkinson's that seems to be ordinary Parkinson's and not something unusual, then we wouldn't do a gene test. Yeah. Okay, so that's really, oh yes, sorry, question here.
Recently we heard of the connection between melanoma and Parkinson's.
Right.
Can you...
So the question is about the connection between melanoma and Parkinson's. It's true that people with Parkinson's have an increased susceptibility to skin cancers overall, of which melanoma is one. And so there's an increased susceptibility, not huge. I mean, it doesn't mean to say you've got to go along, but you should go anyway. We should all get our skin looked at. But there's a relationship, but it's not a large relationship. But yes, there's an increased susceptibility to getting skin cancers, not just melanoma, but SCCs and so forth, if you have Parkinson's. On top of that, and do not get alarmed about this, taking levodopa does increase that risk a bit more. That's metaparacimab. So those medications do increase your risk of getting skin cancers, including melanoma, not by a huge amount, but a bit more. So yes, there's an increased risk, which means that all of us should go and get our skin checked periodically.
While you're on skin, I was just wondering, is there a connection between Parkinson's and psoriasis? I mean, I know that I think people that have psoriasis, there's an excess of Parkinson's diagnosis. Does it go the other way? What is the connection, if any?
I don't know the answer to that, Brian, I really don't. Perhaps I should, but I don't. Have you read about it?
Yes.
You can tell us?
Yeah.
Yeah, but I'm not, yeah, I mean, it's not such a, it's not a strong clinical association, psoriasis and Parkinson's, I must say. Yeah, same with diabetes, there's a bit of an association with type 1 diabetes. Question from the back.
Yes, is there any correlation between occupations and the likelihood of getting Parkinson's?
There was a correlation, as I mentioned just before. So the question, for those who didn't hear it, is there a correlation between occupation and getting Parkinson's, risk of getting Parkinson's? The answer is yes, but it's fairly weak. Unless you're a sort of unless you're a smoking manganese worker or something like that, where you can imprint or lead worker. But for most people, the associations are with rural living, so farmers, as I mentioned before, health workers like myself, teachers, and thought the teachers thing might be exposure to viruses from kids, and health workers, other sort of illnesses, infectious illnesses, I guess. But yeah, they're only weak associations. There's no really strong associations, other than the rare people are exposed to heavy metals, and they smoke and ingest it. Another question.
I've read that there is a connection or a correlation between autistic spectrum disorders and developing Parkinson's.
Yeah, it's pretty, not a strong, the jury's out there. It's all very topical, ADHD and the autistic spectrum disorders, and there are associations with ADHD and the spectrum with lots of different conditions, including Tourette's, and not a strong association, whatever it is, and it's yet to be proven. Yeah.
Peripheral neuropathy.
Yes.
Is there a treatment for that, or how can that be managed, or?
Right. Well, so the question is peripheral neuropathy, which is numbness and tingling and weakness maybe in extremities. Is there a treatment for that? Right. So the first question has to be answered is, can you get peripheral neuropathy as a result of Parkinson's? Are the two related? And for most peripheral neuropathies, no. But there is an increased incidence of a B12, vitamin B12 related polyneuropathy, peripheral neuropathy, causing numbness and perhaps some weakness in the feet, sometimes in the fingers. And especially liable in people who no one here now, who have the duodopa gel. That's a PEG. So that's given by an infusion. In Australia, we don't have it here. We did a trial here years ago, where you have a gastrostomy, a PEG, tube going into the stomach down to the small bowel, the duodenum, which is where your levodopa is absorbed in the small bowel, not the stomach. And somehow that's related to having a bit of a B12 deficiency in a minority of people. And then there is suggestions, and probably true, that people who take levodopa, metatarsumet, are a little bit more liable to getting a B12 deficiency polyneuropathy, which we experience of numbness of the feet and maybe sealing up to the knees. But it's so, and people, yeah, so if I encounter someone with a neuropathy, and by and large, I mean, neuropathies are much more likely caused by diabetes and a few other exposures rather than Parkinson's. But there's no relation between Parkinson's itself and a neuropathy, but it's the treatment of Parkinson's with the levodopa gel and less commonly with just oral levodopa that many folks here will be taking. I don't think you're going to get a peripheral neuropathy because you're taking levodopa. The chances are overwhelming that you won't. But if you do get numb feet, particularly you need to see your GP and get all the tests that we do for people with neuropathy. And if there's treatment for some and not treatment for others. So if you can prove the cause of the neuropathy, such as B12 deficiency or something else, then of course the treatment would be replacement of that.
So if it's not a B12 deficiency, what other things?
Oh, there's a number of different causes. They want to look for diabetes or pre-diabetes and
or not diabetes. Not diabetes.
Well, alcohol can do it. If you drink too much alcohol, there's quite a number of different causes. So you want to be looking for that. I can't give you the full list off the top of my head.
Thank you.
Can a levodopa cause nausea?
So the question is, can levodopa cause nausea? Yes, it can. Yeah. So it's the commonest side effect from levodopa, especially, and people here will experience maybe when you first started it, especially when people first start levodopa, cinnamometaboparin, the main potential side effect would be nausea. And usually that goes away by itself after a few weeks, but you can treat the nausea with two types of medication, domperidone or ondansetron, but not the other anti-nausea drugs which can aggravate Parkinson's. So anti-nausea, things you get across the counter at the chemist, you've got to be careful of because it could aggravate Parkinson's. In some people, the nausea persists, and I've had a minority, a very small minority of people, patients, who have real difficulty getting started on levodopa because of persisting nausea. And those people, I'll try one or two other different medications to see if they'll tolerate those. But eventually most people, or virtually everyone with Parkinson's, will need to be on levodopa to alleviate symptoms. And those folks, you really have to try hard by starting tiny doses of levodopa and going, implementing very slowly. But yeah, nausea is common.
In my husband's case, he didn't get it to begin with.
Right.
It came on later, like
Yes.
a year or so later.
Right.
He started suddenly feeling nauseous. It might have been
Right, so
related to the increase of dose.
Yes, could be. Yeah. So I mean, I can't comment on individual cases, as you probably sure, but in general terms, somebody who develops nausea later in their treatment, which is what we're pointing out here. Either it could be related to an increment on the treatment, or it could relate to bringing in an alternative, such as a dopamine agonist or a Pinerol or pramipexole, which is more likely to cause nausea than levodopa. Or there may be another cause that the GP would have to investigate. Yeah, it's unusual to develop nausea later on the same dose of levodopa. That would make me think it's something else. Okay, just to finish off what I was saying about the cause of Parkinson's. What happens to the individual nerve cells? So you're probably aware that the main features of Parkinson's, the cardinal features I mentioned, are due to degeneration of nerve cells, dopamine nerve cells, at the base of the brain in an area called the substantia nigra, it's the top of the brainstem. And when the pathological changes in the brain, which occur in Parkinson's, and the pathological changes are related to misfolding of a protein called alpha-synuclein, So we're all made of proteins. We're just a bunch of proteins with some water, which is really what we are, actually. We're all made of proteins, and our brain is no exception. Our brain is made up of proteins, essentially. And we all need all these different proteins for our normal brain function. In Alzheimer's disease, what goes awry there is that there's two proteins, tau and amyloid, which we all need for normal brain function. They start to misfold and clump inside the nerve cells, and then eventually when that causes too much damage within that cell, it dies. And the cells are dying off at different rates in Alzheimer's disease, but those are the proteins that go awry and cause the damage. In Huntington's, another neurodegenerative disorder, which is inherited, that's Huntington protein, which goes awry and clumps and so forth. In Parkinson's, it's a protein called alpha-synuclein, which we all need, all of us here, for brain function. But in Parkinson's, what happens is that those proteins, the alpha-synuclein protein inside the nerve cell, starts to misfold, just like a sheet that's instead of folds nicely, it gets tangled up, and then all the sheets join together, fibrils, and then normally the nerve cell tries to protect itself by shunting those clumped proteins into a rubbish tin inside the cell called the Levy body, which you may have heard of. So when the pathologists in the old days looked down the microscope, they could tell something had Parkinson's by seeing the Levy bodies in the nerve cells. Well, that's probably a protective mechanism. The cell trying to parcel off this abnormal protein into a rubbish tin inside the cell. But in the cell, if it can't, the cell gets overwhelmed and eventually it dies. So that's what happens with Parkinson's, this accumulation of misfolded proteins. And when we come to treatment, if we get to that, a lot of the new treatments being tried are trying to prevent that abnormal clumping of the alpha-synuclein and prevent it being passed on to another cell, next cell in the sequence. So what happens in Parkinson's is that these changes, these abnormal clumping of these proteins inside the nerve cell starts at the bottom of the brain called the medulla, that's within the brainstem, and it gradually gets passed on from one nerve cell that's getting damaged to the next healthy nerve cell in the pathway, going up the brainstem until it gets to the top of the brainstem, which is the substantia nigra, which when that starts to get damaged, that's when you get the tremor and the rigidity and the slowness of movement, bradykinesia. So before that happens, before those what we call motor features, the tremor, the bradykinesia, and the rigidity, there are what we call non-motor or pre-clinical and prodromal features, symptoms. And so many of you, if you've got Parkinson's here, or particularly your spouse or your sleeping partner would have been woken up in the night by you acting and talking out your dreams. We call that REM sleep behaviour disturbance. When all of us, when we dream, we generally are pretty motionless, apart from our eyes, which are rapid eye movements. And so when we dream, we're pretty motionless. But people who have Parkinson's or are going to go on and develop Parkinson's will often talk and act out the dreams. That's called REM sleep behaviour disorder. Some of us can do it as we get older anyway, just occasionally, but for people who are destined to get Parkinson's, if a person develops that acting out the dreams, then by and large there's at least a 50% chance that person ultimately will get Parkinson's. So it's a bit like a sort of a predictor, not an absolute predictor, but it's more than 50% chance that somebody who starts doing that will get Parkinson's or type of Parkinson's, possibly MSA. So that's what we call a prodromal symptom. So if you look back, as people do, think, oh gosh, when did my Parkinson's start? Well, probably with many people with that REM sleep behaviour disorder, talking out the dreams, maybe loss of smell, which is common in Parkinson's, maybe constipation, which is common in Parkinson's. It starts before the motor features. And anxiety actually is another prodromal feature. So many people, or the care of a spouse or a partner, will say, oh yes, he or she, more likely he, because it's more common in males, Parkinson's. But yes, starting to get more anxious about things, small things bothered him, which never used to worry him, right? Those are prodromal features, and those prodromal features reflect what's happening at the very base of the brain, as I mentioned, in the medulla, and those are the earliest pathological changes with the alpha-synuclein misfolding. And what happens is the cell gets sick, and either before it dies, it extrudes this alpha-synuclein clump into the synapse, which is a gap between nerve cells, and the next healthy nerve cell takes up that clump it starts to produce its own clumps. And you get this like prion disease, not quite the same, passed on. It sounds awful, but it's not really that bad. And gets passed on from cell to cell. And there's this orderly progression up the brainstem until you get to substantia nigra. Then you get the tremor and the other features, motor features. And then if you're unlucky, then it may go up into the higher parts of the brain, the cortex of the brain, start to cause difference for thinking, concentration, and some people, unfortunately, dementia of the Parkinson's type. So there's this progression. But to the treatment, or the trials, not proven yet, but trials that are happening at the moment are aimed at trying to reduce that passing on the alpha-synuclein from one cell to the next, trying to interrupt it, ambush it before it can infect the next cell, if you like. Not really infection, but invade the next cell, or get taken up by the next cell. So a lot of treatments, a lot of trials now are looking at antibodies to the alpha-synuclein to stop it being passed on, or vaccines, and they're all in trials at the moment, not yet proven. So that's how Parkinson's that's how it seems to develop in the brain. And we talked about the genes and the environment. So that's really what was meant to be the preamble, not being sort of half my time. Go on, so general questions.
Yeah, let's do that.
So there are some questions in relation to symptoms, which you might deal with first. And some of you who've written this might want to clarify it, if I've got it right. Someone's written, fatigue is a major symptom for my husband. We would like to know what causes it and how it can be counteracted. Yeah, fatigue is almost universal in Parkinson's, as it is with many other neurological disorders. Actually, we don't really know what causes the fatigue. There's no simple answer. No one really knows. If you know, then I'd like to hear about it, because you could get a Nobel Prize. No one really knows, other than it's common. It's almost universal, but some people get more fatigue than others. We have to separate fatigue from sleepiness. So there are two different symptoms. Some people feel sleepy with their Parkinson's, especially on the medication. Some medications are more likely to cause sleepiness than others. But that's different from fatigue, as you'll know if you suffer from fatigue. We don't know the cause really. What can you do about it? One way is to try and build up stamina through exercise. Another way is to make sure you get a decent sleep at night if you can. Make sure there's lots of causes of why people with Parkinson's have disrupted sleep. We could cover that at some point. But yeah, exercise, building up stamina is probably the best, having a healthy diet and so forth. But there's no easy answer, actually. Yeah. Any questions on that? I don't, well, just as well, but I couldn't answer them properly. Yeah, it is a really important symptom, but it's really one of those symptoms that we really struggle with in terms of treatment. Next one here on my list is, why are the symptoms of Parkinson's disease so different in different people? Which is true, and as I mentioned at the beginning, it is true. Everyone with Parkinson's, as my colleague Barry Snow used to say, and I've taken up that sort of thing, you see one person with Parkinson's, you've seen one person with Parkinson's. In other words, everyone's different. The way it comes on, the symptoms that people, there's a myriad of symptoms, of course, that you can experience with Parkinson's, the non-motor, which is what I mentioned, and the motor, and the cognitive, and the autonomic, the low blood pressure. There's a huge array of symptoms. Parkinson's, more than any other condition I've ever dealt with in neurology. So those of you who have been greedy enough to get Parkinson's will you've been greedy enough to get the biggest array of symptoms that people could have. But you don't have them all. So one person will have one set of symptoms, the next person will have another. And so so why is it so different in different people? I think I've probably touched on that before, the genetic susceptibility, the environmental exposures, and other factors we don't really know, but we do need to know so we can tailor treatment at a particular individual who's got that different type of Parkinson's, if you like, from the next.
Tim,
Yes.
just going back to the prodromal
Oh, yes.
things. If someone you know starts experiencing one or more of those symptoms,
Yes.
what's the best course of action?
Well, first of all, not to worry them. The thing is, and I haven't gone on to treatment much, we do not yet have a proven medication or treatment of a non-pharmacological sort that will slow down or even prevent people getting Parkinson's. this is the biggest challenge, isn't it? And it's sort of the most depressing thing so far, that throughout, there's zillions being thrown at Parkinson's, excuse me, trying to find a course of treatment and trying to find a preventer. We've not found one yet. So, sorry, I'm going to sip of water. So at the moment, given that we don't have anything that will prevent people getting Parkinson's, who have these prodromal symptoms, then there's nothing that we can really do other than say try and keep healthy, exercise, all those things that you can try and do yourselves. Either treat your own Parkinson's and also help prevent it coming on. I'm just going to turn this off so I can cough properly. Sorry. Okay, some water. It's a good question. It's a good question. And you can, if you look at these prodromal features, add them together, you can almost give an 80% prediction that someone might get Parkinson's. So we need to be ready, for when we have a decent preventer. Yeah.
Thank you.
You said nothing can slow it. I mean, is there any evidence about? There was a fellow in South Africa who was written about and who I think developed a technique called mindful walking. I think it was.
Yeah.
So is mindful exercise? I mean, can you slow the progress? I mean, you say exercise is good, diet is good, social contact, all those sorts of things. I mean, can something like mindful walking make any difference whatsoever?
The best evidence so far is still in the works really is exercise. That's more than diet, more than other things. In general, to keep brains healthy, you've heard it time and time again, keep up social contacts, have a healthy diet, Mediterranean style diet, and exercise especially. So there is good emerging evidence that exercise can slow down progression of neurodegenerative disorders. Looking very likely that will do that. Mindful walking, I would do something like mindful, really vigorous exercise rather than walking's good, and it depends on what your capabilities are. I mean, obviously some people can't walk too far or need walking aids, so you do within your capabilities. But you can, there's the emerging evidence is for vigorous exercise.
So high intensity is
high intensity is what I mean. Even short bursts. 30 seconds a day, something like that. So you're better to exhaust yourself, well, not exhaust yourself, but really go for it. Maybe on a stationary bike if you can't walk up hills and things. To get yourself puffed. Theoretically, getting yourself puffed that you can't talk is probably what we mean by vigorous exercise. And if you do that, even short bursts, a few times a week, even 30 seconds, 45 seconds, that's probably better than ambling around the park. Being sort of thinking mindfully. Whatever mindfulness is. But it's nice to think mindfully, and it's probably nice, generally it's good for you. But I think that for brain protection, you've got to go for it.
Thank you.
The way, in the ways that you can. Yeah. I think I've cleared my throat, so we can carry on. Thanks. Here's a question. Are Parkinson's sufferers likely to experience Sundowner syndrome? Sundowner syndrome is the sort of thing we don't really talk about I don't much in my clinics, but it's something that residential homes, dementia homes tend to talk about a lot. The Sundowner syndrome, if you are aware of it or not aware of it, is a tendency for people later in the day, early evening, to sort of start to be more confused, potentially, not feeling so well, fatigued and so forth. It's certainly a phenomenon in people with dementia, not everyone, and it's a phenomenon that's noted in Parkinson's. And it probably relates to the fatigue that people get, the medications in themselves probably, as the day goes on, probably promote to some extent that a less what's the word, beneficial response late in the day. So some of you with Parkinson's will know that in the mornings you're really good, pills are working well, later in the day just don't seem to give the same response. And there's even a suggestion that taking the medication with Parkinson's, levodopa for example, in itself changes the response later in the day to be not quite as good as the response in the morning. Then you sleep overnight, the whole thing gets restored, and that happens again. So the Sundowner syndrome, in terms of managing, best to try and keep the routines, have plenty of rest or sleep, keep a healthy diet, but routine seems to be something. Yeah. Something. Here's a curious one. Why is there a feeling like someone's scratching the bone of my left lower leg? Well, it's a hard one. But it sort of raises, there's a syndrome called restless legs, which you've probably heard of, a very common symptom. A pregnant woman will often get it, 21% of pregnant women get restless legs. Other people will develop restless legs sometimes later in life, sometimes it's familial. Restless legs is the feeling of the urge to move the legs more than the arms. And people who suffer from restless legs tends to be later in the day or in the early evening or lying down in bed. And there's a real urge, it's a funny, unpleasant feeling in the legs, but the urge is to move them to relieve that feeling and maybe get up and walk around. People with Parkinson's are more liable to get restless legs than people who don't have Parkinson's, so it's a common symptom. It's also common in Parkinson's that people have been treated with levodopa, and then if the levodopa starts to wear off before the next dose is due, then that will cause a similar feeling. And I'm sure some of you have experienced that, either waking up in the night or maybe later in the day with the urge to get up and walk around to relieve some sort of funny feeling of tension in the legs, tension in the body. And that's restless legs. And it's treatable by basically medication, either increasing the levodopa, more likely adding in a dopamine agonist like ropinirole, pramipexole. But whether that person with the feeling of something itching in the leg, in one leg, it's unusual just one leg, so I can't really answer that with any degree of confidence. But it could be a sciatica that's causing unusual something, I don't know.
I have to say that I get something very similar to what the person was talking about.
Yes, a restless feeling?
No, not restless. Like somebody's touching you, but there's nobody there.
Ah, right.
Just sounded like cold water at one point running down your leg.
Right. The feeling of cold water running down the leg can be due to quite a few different things, including spinal cord problems due to the neuropathy that someone mentioned here, if it's of both. Yeah. But I've seen young people with multiple sclerosis have that feeling because they've got a spinal cord lesion that causes something similar. So, but that won't necessarily pertain to you. Yeah. So don't suddenly think that you've got. Yeah. But it's not an uncommon symptom, to be honest. The vivid dreams and night terrors, what's this all about? Right, good question. So I mentioned the REM sleep behaviour disorder, where people talk and act out the dreams. Those people generally are asleep, and so it's the bed partner who suffers and may be hit or woken up with shouting, screaming. Men tend to dream of fighting off things, animals, people. Women less so but can. And that is really that person may remain asleep unless they're woken up by the sleeping partner who's woken up by this person doing this. But and if the person is woken up or does wake up, they may remember that rather frightening or vivid dream. Yeah, but people with Parkinson's are more likely to have vivid dreams anyway, especially on the medication, the levodopa or the ropinirole, the dopamine agonist, will cause or aggravate vivid dreams in itself. So you can have vivid dreams without acting them out, and they can be, if they're frightening, then one has to try and treat those. Or you can have dreams that are not necessarily vivid to yourself because you're asleep and therefore unconscious, but you act them out. Or you may have a combination of both. You may have a vivid dream which you act out and wake yourself up. The treatment for REM sleep behaviour disorder, that talking and acting out the dreams, is high dose melatonin, higher than what people have normally just to sleep, 12 milligrams up to 12 milligrams sometimes, or clonazepam, which is a benzodiazepine related to Valium, which can be very effective as well. The vivid dreams by themselves without the dream enactment, then it's probably related to and some people taking too much anti-Parkinsonian medication at bedtime. So sometimes reducing that nighttime dose can reduce the vivid dreams, as long as that doesn't cause restless legs and the person waking up not able to move and being uncomfortable. So you sort of have to treat each case very individually. I think that's the end of the symptoms that people asked about here. Unless there's anyone else with a...
Saliva control.
Saliva control, yeah. There is some people tendency to dribble, and that's not due to too much saliva. So it was thought to be due to producing too much saliva. In fact, it's not swallowing automatically. And so when people dribble with Parkinson's, often the first inkling of that is at night, and waking up in the morning with a wet pillow, with the mouth open. And then that can sometimes spill into daytime with some dribbling down one corner of the mouth. Some people have a feeling of dribbling, but it's not there. But anyway, it will damn the saliva. Yeah, so it's not due to too much saliva, it's due to not swallowing it automatically like the rest of us do. So all of us here will be swallowing automatically without thinking about it. In Parkinson's, because of this slowness and the incoordination, the muscles of swallowing also can be involved, as you're probably aware. And so the automatic swallow of saliva in the mouth, sort of initiating the swallowing mechanism, may not be there. Or if it is there, not coordinating the swallowing properly. So that the saliva will pull in the mouth. And then if you're leaning over, reading the newspaper, eating, out it comes. And of course, for some people with Parkinson's, the mouth will be open a lot of the time, just as part of the Parkinson's. So some people with Parkinson's have a mouth that hangs open as part of their Parkinson's, and that will encourage obviously saliva to spill out rather than being swallowed. You can dry the saliva up, but that actually makes things worse. Usually the person gets a uncomfortable dry mouth. Very severe cases, we can use botulinum toxin, Botox, into the salivary glands, which will dry up the salivary glands. And that could be effective in some people. But otherwise, my preference is to get people to try and automatically swallow, well, not automatically, voluntarily swallow. Just think, swallow, just like people who've got soft voice in Parkinson's, you have to think loud, speak loud. It's a nuisance. In the old days, when the dentists that used to have the squeegee things that suck the saliva out rather than the suckers they have now, we used to furnish people with one of those dental things and they could suck their own saliva out. So they had to. Okay.
Excuse me, where does dopamine come into all this?
Where does dopamine?
Yes.
Right, where does dopamine come in? Dopamine is the neurotransmitter that is missing in Parkinson's because the nerve cells that die off, ones I mentioned in the substantia nigra, when you get to the top of the brainstem, those nerve cells are what we call dopaminergic. They use dopamine, the chemical dopamine, as their neurotransmitter that makes the next nerve cell, stimulates the next nerve cell, the pathway which is normal, to act. So when you have a loss of the dopamine from those nerve cells that are dying off, then you develop the symptoms of Parkinson's. Yeah. So dopamine is a mainstay. It's not the only chemical, not the only neurotransmitter involved in Parkinson's, but it's the dominant one. And so most of the treatment that we use is aimed at sort of replacement of the missing dopamine. We don't replace it physiologically because all of us are just dribbling dopamine at various levels at various times as needed. In Parkinson's, what we're doing is giving people pulses of industrial doses, if you like, but it is for the nerve cell, and sort of big doses intermittently, and that can cause problems down the track, as you know, with dyskinesia and so forth, and wearing off from medication, most of which we can cope with, but yeah, that's where dopamine comes in.
Can diet be helpful? I mean, with the dopamine replacement, I don't know, banging in more broad beans or something.
Yeah, well, I would. Well, you've got to get it right. So, I mean, how much dopamine is broad bean?
Don't know.
And there is. So at least Roche and all the other pharmaceutical companies, although they might be making lots of money, they've also got it right in terms of the dose that you get, so you know what you're getting. There is a natural product called I'll slip the mic at home. From India. You remember its name? Yeah, it's got basically dopamine, natural product dopamine. But the trouble is, you've got to give huge doses, because in the old days when levodopa was first discovered in the 1960s, it was only given as levodopa, and you had to give big doses, and those big doses made people vomit all the time, material. It was only when people discovered the inhibitors, which is, if you take some met, you'll see that the proper name is levodopa carbidopa. And if you take metapar, it's levodopa benserazide. Well, that carbidopa and benserazide, they're inhibitors of the breakdown of the levodopa in the peripheral nervous system. That allows smaller doses to be given and allow it to get into the brain without these huge doses that cause nausea and vomiting. So that natural product name just forgotten can cause a lot of that issue.
That probably brings to another question that someone had. Do you have any, there is a question here that says, are there any natural products out there that are recommended to help with Parkinson's?
The short answer is no, for the reason I just mentioned. There's all sorts of diets we have tried. The keto diet, that's not really proven, to be honest, to be useful, and it can be unpleasant. There's modifications of that. If you have a normal, healthy diet with lots of vegetables, and as I say, sort of based on the Mediterranean diet, that is all you need. But if you're deficient in some aspect of your diet, then that obviously is a problem. But no natural products that I can recommend, actually, to be honest. Doesn't mean to say you can't take them. If you want to take them, that's fine, as long as they don't do any harm. But really, nothing in the natural world is really been proven. And as I mentioned, there's this natural form of levodopa, of dopamine, but you're better off to have, it's too expensive, and you're better off to have the manufacturer's product, which we know doses of.
What is the difference between Lewy body dementia and Parkinson's-related dementia?
Good question. So the question is, what's the difference between Lewy body dementia and Parkinson's dementia? I mentioned the Lewy body before as the pathological hallmark when someone looks down the microscope in the brain of someone that says that person's got a Parkinson's disorder. And so that's where the word Lewy body comes, but it's the alpha-synuclein, which I mentioned before, which is the key player. So, as I mentioned, maybe up to 50% of people with Parkinson's may ultimately, if they live long enough, get a form of dementia called Parkinson's dementia. That is, by definition, a Lewy body dementia. And for most people, it comes much later in the course of their condition, if they're going to get it. They don't die of a heart attack or something like that. If you develop your dementia either within a year of your Parkinson's or before your Parkinson's symptoms, and it's of a Lewy body type, then we call that dementia with Lewy bodies, which is different from Lewy body dementia. So Lewy body dementia is the dementia of both Parkinson's disease and someone who gets Parkinson's, and then at some stage later, beyond a year, gets dementia. For most people, it's much later in the year, but the other form of Lewy body dementia is dementia with Lewy bodies. That's a bit of a tongue twister. And dementia with Lewy bodies, by definition, is that dementia comes either first, before the Parkinson's, or pretty much at the same time. The real debate amongst people, and it's still not sorted out by clinicians and researchers, is are they the same condition but just at either end of the spectrum? So if you get your dementia, then you get your Parkinson's soon after. Do you just have a form of Parkinson's that, unhappily, has dementia as a beginning of it? Is that the same as someone who's had Parkinson's for 20 years and finally gets a bit of dementia at the end of that, but they're the Lewy bodies in the cortex? So some people argue that they're all the same condition, it's just a different end of the spectrum. And like I say before, we're all different with Parkinson's, and you have variation to make genetics or whatever. So no one really still knows whether they're the same condition, but two ends of the spectrum, where they're two different disorders. There's arguments either way.
So if you've got,
whichever the treatment is the same.
You've got Parkinson's and then you develop dementia.
Yes.
Is there any value in trying to find out what kind of dementia it is you have?
Right. Good question again. So the question, for those who didn't hear it, is if you have Parkinson's and then you end up getting dementia, is there any point in determining what sort of dementia it is? it's a good question because Alzheimer's dementia, Alzheimer's disease, which then ultimately, Alzheimer's disease is having the pathological changes, Alzheimer's dementia is having the dementia that goes with the pathological changes, right? So you can have Alzheimer's disease without having dementia. You know, some people, I might have Alzheimer's disease, I probably have, and you know, I might do. Some of you might have it and not be aware of it because we've got the changes happening in the brain, just like the changes of Parkinson's happen early. You know, the prodromal cells before the other features develop. You can have Alzheimer's disease, which eventually may or may not result in dementia, right? So you could be run over by a bus, and people would like this, and have a post-mortem, and they might find Alzheimer's disease pathology in your brain, but you never actually had the cognitive changes that end up with dementia. Maybe if you'd lived another 20 years, you might have, right? So why don't I go on that tangent? Yes. So the older you are, the more likely you are to have a mixed pathology. So Alzheimer's disease is much more common than Parkinson's. Even though Parkinson's is getting more common, maybe 2% of people over 65 with Parkinson's, more people with Alzheimer's. So once you get to 85, then you've got almost a 20 to 30% chance of having Alzheimer's. Right? So if you're a Parkinson's person and you're 80 or you're 75, 80, 85, you have quite a chance of having Alzheimer's pathology in your brain to go with your Parkinson's pathology, which we know you have because you've got Parkinson's disease features, right? So you're entitled to have two pathologies. The Alzheimer's disease, the cognitive change of Alzheimer's disease is a little bit different in many ways from Parkinson's, more memory impairment than Parkinson's by and large, whereas Parkinson's is more as what we call frontal executive problems like decision making, planning ahead, those sorts of things. And then there's vascular, right? So the older you get, the more prone you could be to having vascular changes, which, you know, I don't mean strokes, but just changes in the brain, small vessels that block off that you may not be aware of, never had symptoms of, but when the pathologist looks at your brain, they might find these vascular changes in the brain, deep in the brain, that could contribute to your cognitive impairment. And so there's three types of pathology that could be present in a person with Parkinson's. One we know will be the alpha-synuclein change, right? This is a person with Parkinson's with cognitive impairment I'm talking about. There'll be the Parkinson's changes, which you'll evidently have, but you may have a certain degree of Alzheimer's pathology, and you may have some vascular change. Vascular change not so important as the other. So in our research program at the Institute, some people with Parkinson's have been involved in our longitudinal study, have incredibly generously donated their brains, and so at the time of death, the brain is harvested, if you want to call it that, and sent to the Auckland Brain Bank. And so now we've got a number of people who in this situation who donate their brains, and we are finding this very thing, that not many people have absolutely pure Parkinson's changes. Some do, who die with maybe dementia, they have a purely Parkinson's dementia. Some people have quite prominent Alzheimer's changes as well. And you wouldn't necessarily be absolutely active in finding that during life. So it's going to be important when we get a treatment for both those conditions, right? So if we get a good treatment for Parkinson's, so someone asked about cures, there ain't a cure yet. If we get a good treatment for that, then obviously it's important to identify, is this person's cognitive change mainly due to their Parkinson's, or maybe it's more due to Alzheimer's changes, and we should be concentrating on that. So when we get a treatment for Alzheimer's, which we haven't got yet, but it's getting there, and when we have a treatment for Parkinson's, I don't mean symptomatic treatment, but preventative treatment or treatment to try and reduce the consequences, then it'd be important to look at pathology. And the way you can do that in life now is PET scans. So we can look at the brains of people in life with Alzheimer's, the amyloid pathology I mentioned, and you can see the amyloid in the PET scan. And now there's emerging now, beginning to finding, you can get traces now with PET scans that can look at the alpha-synuclein problem in Parkinson's. So in a few years' time, if we need to, in research initially, you'll be able to find those changes in the brain, not at post-mortem, but during life, doing a PET scan. I think time's up, isn't it?
I am conscious of everyone's time. Gosh, we could just keep going and going and going.
Right,
So
maybe the last question, do you think?
Yeah, there's one question, and then there was just a question I know has come from Attribution regarding deep brain stimulation.
Oh, okay.
And
Brian, you might
when's
speak
a
to
good
that.
time, but we'll go with you.
A quick one?
Okay, quick one. Is, look, you were talking about neuropathology. You're in a path lab, you've got two brains, and you're looking at these neuropathologically. One of these patients had dementia with Lewy bodies, the other patient had Parkinson's, but you don't know which they are.
No.
Could you, by looking at these brains, tell which was which?
Well, you don't know the clinical symptoms, without knowing the clinical story. Well, you can tell which person has the pathological changes, but you will not necessarily know unless there's so much asymmetry, so there's overwhelming Alzheimer's changes, very minor Parkinson's changes that may not have been, some people die with run over by a bus and you find some Parkinson's changes, the person never presented in life with Parkinson's. Just as some people with Alzheimer's changes never present with Alzheimer's dementia. So that person, you can have a bit of a clue depending on the balance of the pathology.
Okay, thank you.
DBS.
Yeah.
What was the question in relation to DBS?
Is around what is the procedure, and then also about timing.
Oh yes, okay, yeah. So deep brain stimulation, not sure if anyone here has had DBS, deep brain stimulation. Deep brain stimulation is basically putting probes into the brain, into the areas, not the substantia nigra, but the bit where the area where the substantia nigra feeds to, which is called the striatum. And if you put probes in there, thin wires, and stimulate at high frequency, 100 hertz, you turn off that particular bit of brain, which actually, paradoxically, actually helps the symptoms. A bit like levodopa does, but in a different way. So people with deep brain stimulation, having that treatment to treat complications of levodopa in the main. So after people be on levodopa for a substantial period of time, or not that long, there may be side effects of that treatment, including dyskinesia, which are extra movements, sometimes quite vigorous extra movements, which are a problem. Sometimes you can't get the dose of levodopa up because of these other side effects will not allow you to treat the person adequately. So those people, if they're under 70 and don't have any cognitive change and are otherwise healthy, may go forward for deep brain stimulation in Auckland to have this treatment. The best response to deep brain stimulation is no better than the best response to levodopa. Just so it smooths it out, it gets rid of the dyskinesia and allows that person to have a much more even day and without the major fluctuations. We used to reserve it for people who were quite well down the track and having major difficulties with their medication, as long as they're under 70 and didn't have too much of a cognitive change. There's been a gradual move over the last decade to treat younger people who don't necessarily have to have, particularly advanced problems and don't necessarily have to have a lot of fluctuations, but some fluctuations. So the answer is yes, deep brain stimulation, DBS, is now being offered to younger people who are not particularly disabled by their symptoms more and more. But remembering that you don't get any better response from deep brain stimulation, than you do from the treatment from the levodopa. You may have heard of focused ultrasound, which has been offered in Australia. That's best for essential. It's good for tremor, focused ultrasound. So that's basically very narrow focused ultrasound to the area of the brain affected by, involved in generating tremor. And so some people with Parkinson's who've got bad tremor may be suitable for this focused ultrasound. It's given with the skull intact as opposed to deep brain stimulation, you drill a hole in the skull. But it's not as good for people with Parkinson's other symptoms, the rigidity and the bradykinesia, as deep brain stimulation. It's best for people who've got essential tremor, just got tremor and no other Parkinson's features. But you may have heard of that. Probably exhaustive one, I think.
No, I think, gosh, it's just fantastic, and you've done amazingly well, and we're so grateful just for the opportunity where everyone can kind of ask all their questions, and if you just have those little things, and it's so wonderful to just have the time.
Well, sorry I haven't answered anyone's questions at the paper, so if you didn't get your question answered, I apologise.
So yeah, I think that everyone's certainly done their best to present the questions and to have them answered. So yeah, just an enormous thank you.
No, thank you everyone.
from us.
Thanks for the questions.